medical school at Johns Hopkins University in internal medicine and his pulmonary critical care fellowship at University of Washington. And then subsequently, he completed a 2-year Robert Wood Johnson Faculty Scholars Program where he focused on palliative care research. He's currently a pulmonary and critical care physician and palliative medicine physician at Harborview Medical Center, and holds a whole list of honors, including the inaugural director of the Cambia Palliative Care Center of Excellence at the University of Washington. He's received strong funding support from the NIH and other foundations for over 15 years, and has been very active in the NIH study sections, et cetera. He has a really impressive CV with greater than 200 publications centering on palliative care, and on a personal note, his research has been really instrumental to me and my interests in my chosen career and academic interests. So it's with great honor that I introduce Randy Curtis.
Great. Thanks, Nick. Well, thanks very much. It's a pleasure to be here. It's been, I think it was about a decade ago I made a visit to Duke, and so it's been a little while. It's changed quite a bit, but it's fun to be back. Is my microphone live? Okay, excellent. I muted it when I went to the bathroom. Did you ever see that movie with Leslie Nielsen? And I figured I didn't want to do that. So, all right. So what I'm going to talk about this afternoon now is some of the work that we've done around measuring and improving communication about palliative care with patients and families. And this afternoon, for the pulmonary group, I'm going to talk about our work focused more in the intensive care unit. I have no financial conflicts of interest to disclose, but I do like to disclose and acknowledge our funding sources. And in fact, our healthcare system, UW-Madison, has been a big funder of our palliative care efforts, primarily clinical, but also research and education, particularly to the extent that we integrate that with our clinical programs. Our center was received a very large, and we're very grateful for a gift from the Cambia Health Foundation, which is based in Portland and now carries the name the Cambia Palliative Care Center of Excellence. And then the research I'm going to show you today was funded by the NIH and particularly the National Institute of Nursing Research, which has really taken a lead on funding palliative and end-of-life care research within the NIH. And then we also have funding from PCORI as well. And so what I'll cover is these questions. What is communication about palliative care and why is it important? How do we think about measuring the quality of that communication with the idea that if we can't measure the quality, it's hard to know whether we've made it better. Whether interventions can make a difference. Is this an innate thing that you either have it or you don't, or can we make a difference? And I'll try to convince you that we can. And then I'll talk about 2 of our recent randomized trials looking at trying to implement the interventions and seeing whether we, in fact, make a difference. I'll invite questions and comments as I go along. It's more interesting for me if you interrupt me with questions and comments as we go. I do like to start with a definition of palliative care. I think more and more I'm speaking to people who understand what palliative care is, but I think it's important that we have a common language when we think about palliative care. And this is a definition that I like, was developed with a significant amount of input from a large number of stakeholders by the CAPC, the Center to Advance Palliative Care. And that is that it is specialized medical care for people with serious illness focused on providing relief from symptoms, pain, or stress of a serious illness, whatever the diagnosis. That the goal is to improve quality of life, that it's provided by a team of doctors and nurses and other specialists who work with the patient's other doctors to provide an extra layer of support, and that it's appropriate at any age and any stage of a serious illness and can be provided together with curative treatment. Really getting away from this either-or mindset that we started with in this field of either you're receiving curative care or palliative care. And I think we're really learning that, in fact, that is the wrong way to think about it. And that palliative care is much more than just end-of-life care. That palliative care includes end-of-life care. It's an important part of palliative care, but palliative care is much broader. Care for patients with serious illness, identifying goals, treating symptoms, and improving quality of life, whereas end-of-life care is really care for those who are actively dying. And hospice, at least that word, the way that word is used in the US, is a particular model, a very good model, but a particular model of end-of-life care that doesn't apply to all patients who are dying, but can be very helpful when it does apply. And I think that If we equate palliative care with end-of-life care, we really miss enormous opportunities to provide good quality care for patients with serious illness that we don't recognize as imminently dying, or that in fact may not be imminently dying, and may actually even survive this particular illness. But the stress and burden of a serious illness on them and their family can really be quite dramatic, and we have an opportunity to intervene in that. This broad definition of palliative care, I also think it's very important to think about palliative care as falling into these two categories or groups. We have primary palliative care that's provided by all clinicians who take care of patients with serious illness, and then specialty palliative care that's provided by palliative care specialists. And in fact, I think one of the biggest frontiers and one of our biggest challenges is to figure out how to improve both of these and how to have them be working together in a way that's efficient and effective. We don't have enough palliative care providers to see everyone with a serious illness, and I frankly think that would be a silly way to approach care for these patients. But by the same token, there are many situations where primary palliative care does not fully meet patients' needs and families' needs, and that especially palliative care can be very helpful in doing that. And I also think that as the palliative care specialists in the room and in the country need to think about their roles for improving communication, both helping to improve primary palliative care communication as well as specialty palliative care. So I think often the palliative care specialists are the ones who can be available to help provide education around communication about primary palliative care and provide support for those clinicians providing this communication, this primary palliative care communication, if you will, either by seeing patients and providing support that way, or by directly providing support to the clinicians themselves, feedback, advice, support, and so forth. And then there are particularly difficult situations where it may be important to have a specialist involved in helping give bad news in a very tricky, difficult situation, conducting advanced care planning where that doesn't seem to have gone well in the primary palliative care setting, and establishing goals of care when those are particularly difficult. And I think that we need to be able to sort of think about how do we support both primary palliative care and specialty palliative care. I will say as an aside that I think some people argue that if we improve primary palliative care, we'll need less palliative care specialists. My experience is the opposite, that as we improve primary palliative care, then those clinicians recognize unmet palliative care needs more and actually call the palliative care team more and more effectively for cases where the palliative care team can really provide some additional help or benefit, or sometimes where additional help and benefit is hard to provide, but the palliative care team can get involved and try to help provide support. So what's the evidence that palliative care makes a difference? This is a study that may be familiar to many, really a landmark study, not the only study showing the value of palliative care, but a landmark study published in the New England Journal of Medicine in 2010. These investigators based at the Massachusetts General Hospital took patients with metastatic non-small cell lung cancer and randomized them to two groups: usual care in this high-quality oncology clinic and usual care plus early palliative care. What they showed is that the group that got randomized to early palliative care had higher quality of life. They used this TOI scale, which is commonly used in oncology to measure quality of life. Quality of life was improved. They showed reduced symptoms of depression measured with both the HADS-D and the PHQ-9 in the group that got randomized to early palliative care. And then what came as a surprise to the investigators was that the group that got randomized to early palliative care actually survived longer than the group that got randomized to usual care. This was not anticipated. It was not something that they had as a primary outcome. And in fact, Jennifer Temmel, when she shows these data, downplays this survival benefit. Most of us don't feel like this survival benefit is going to be seen in a lot of other diseases. We don't know exactly why there might have been a survival benefit here, although it has been replicated in other patients with advanced cancer. And what they did see is that the group that got randomized to palliative care were less likely to get chemotherapy in the last 2 weeks of life. So that may be the mechanism that would extend life. That's a good question. How what was the sample size in this study? I want
So
to,
they didn't power for that. That's why they didn't.
Right, big deal. That was where the question was.
but it's statistically significant. So they had the power to show the difference they saw. You could argue about statistical stability, and I think that may be true, but the number of deaths were not such that a few people dying in the other group would have made the difference. And frankly, I should know this, but it's been long enough since I've read this paper that I don't remember. But I don't think statistical stability. I think this is one study. It may have been it may not be replicated. Although it has, Marie Bakitas' study showed a survival benefit as well. So I think that in these patients who may get very toxic chemotherapy at the end of life that may hasten death, that makes sense. I think for patients with COPD, heart failure, and so forth, most of us don't think palliative care is going to have a survival benefit. But one question that comes up is, well, what did this intervention do? It's a little bit of a black box to say, let's go have them see these, really good palliative care providers. What did they actually do, and could this be replicated in other places? And these investigators actually did, I think, a very nice follow-up qualitative study where they looked at the palliative care notes in a random sample of 20 patients that were randomized to the intervention arm. And look to see what the palliative care providers said that they did with these patients. And they found 7 key elements in these palliative care notes. Relationship rapport building, addressing symptoms, addressing coping, establishing illness understanding, discussing cancer treatments, end-of-life planning and advanced care planning, and engaging family members. And I would argue that at least 6 of these 7 are directly focused on communication. And I think it's one of the reasons that I've really focused my research program on communication. I think this is not the only important part of palliative care, primary and specialty palliative care, but I think it is one key part of it. There's also some data from Australia to show benefit of advanced care planning. This was a randomized trial for patients who were admitted to the hospital over age 80, randomized to either advanced care planning by a trained facilitator or usual care after hospital admission. And they, of the patients randomized to receive advanced care planning, 81% actually got the intervention as planned, and 56% of them completed an advanced directive. They used an approach to advanced care planning called respecting patients' choices, which is actually proprietary and has, I think, slowed dissemination a little bit. Importantly, they did it in collaboration with the physician. So the physicians weren't asked to do the advanced care planning. It was done by these folks trained in the respecting patient choices approach. But the physicians it was in collaboration. The physicians were there at the beginning, endorsed it, and then got feedback afterwards. Importantly, families were present for 70% of these, which I think is probably a very important aspect to implementing improvements with advanced care planning. And these sessions took a median of 60 minutes. So this is not something that I think in our healthcare system we're going to get physicians probably to be able to do, at least not hospitalists and people usually taking care of these patients in the hospital. The intervention was associated with a significant reduction in death in the ICU, 0% in the group that randomized to advanced care planning on an intention to treat analysis, 14% in the control group. Here I did put the N, 309 total. They had a significant reduction in PTSD, depression, and anxiety amongst family members in the group randomized to advanced care planning, and significantly higher ratings of satisfaction with the death and satisfaction with care amongst the group that got randomized to advanced care planning. So suggesting that, again, basically a communication intervention, in this case in the form of someone trained to do advanced care planning, changed the care that people received and reduced the stress of this process of a serious illness on family members, as well as improved satisfaction with care. So that's to make the case that there is some evidence that working on communication, improving communication, can improve patient and family outcomes. And I've spent a fair bit of my time thinking about, okay, that's great, but can we have an intermediate outcome measure? Can we measure the quality of communication as an intermediary that might allow us to do phase 2 trials with smaller numbers than we would if we looked at patient outcomes. And here's a physician talking to a woman in the waiting room saying if it's any consolation, toward the end he was as high as a kite. So, maybe good symptom control, but not ideal communication. So how do we measure communication? And I sort of think about a couple of different sort of big buckets in the approach. One is to actually audio tape or videotape that communication and to watch the actual communication, have it assessed by experts, for example, or use quantitative scoring tools that you can train research coordinators and research staff to go through and score the communication. And that's one way to assess the quality of it. And I'll show you some examples of studies that have used both of those two approaches. And then I've also been very interested in understanding the patient's experience of communication. And, I think that there are some problems with that, right? That patients may experience very poor communication and have low expectations and rate it very highly, and I think we see that. We also see some evidence that communication in which doctors are effectively giving prognosis actually gets worse quality ratings from patients than communication where the doctor just avoids the issue or doesn't effectively communicate prognosis. So there are some real problems with using the patient experience, but I think you can argue that the patient experience is an important facet of quality of communication. By no means the only important facet, but one important facet. And we could assess that either by surveys, and I'll show you some of our attempts to do that. We could also do semi-structured interviews with patients afterwards. Not something that I've done, but I think I may actually be interested in doing that in the future because I think that allows you to really understand what patients are experiencing and put that in context. So we set about to develop a survey to understand patients' ratings of quality of communication, and we wanted to do that by first asking patients as well as family members and clinicians what was important to them about doctors' communication about end-of-life care. We did a qualitative study using focus groups and one-on-one interviews with patients, families, and clinicians and developed a conceptual model for physicians' skill at providing end-of-life care. One of the 5 major domains or components of it was communication skills. And we used the information we got from, particularly from patients, also from families, to identify items or specific areas that we would ask about on a survey. We developed the survey based on the language that they used. We came up with 13 items for this survey, tested it in a hospice setting as well as in patients with oxygen-dependent COPD, and found that it factored into 2 subscales that had good convergent and discriminate validity, and I'll show you that some of that. The 2 subscales were general communication skills, things like how well does this doctor do at listening to things you say. There were also 7 items that factored into what's something we called an end-of-life care communication skills, things like talking about prognosis or talking about what might happen if you get sicker. They were internally consistent as scales, but also there was internal consistency for the entire scale with an alpha for the whole scale of 0.79. What I now know is this winds up being a pretty low bar for an individual scale, and we've done some structural equation modeling on this as well, and I'm less confident in the total score, but we have been able to validate the individual subscales, the general and the end-of-life care subscale. And we don't have a gold standard to check criterion validity of this, but we have construct validity. It correlates with things that we think it ought to correlate with. Both scales correlate with the patient's overall rating of communication by that doctor, higher with the general scale than the end-of-life scale. It correlates with their overall rating of care, again, higher for the general scale. It correlates with the number of end-of-life discussions they report having had with that doctor, now higher for the end-of-life care scale. And it correlates with the doctor's knowledge of the patient's preferences. And again, a little higher now for the end-of-life care scale. So some evidence that it tracks with things that we think it ought to track with, so-called construct validity. We were also interested in whether trainees, in this case internal medicine residents and fellows in a number of areas, whether their own self-assessment of their communication skills correlated with patients that they saw, their patients' assessments of their communication skills. And we've got these data. Absolutely no correlation whatsoever. There's one poor person down here who probably has a pretty good assessment of their communication skills, but by and large, really no relationship whatsoever. And I show this because I think, if you look at the studies of interventions to train people communication, self-assessment of their skills is one of the most commonly used outcome measures for those studies. And I think it's profoundly problematic. Bob Dixon was a fellow who worked with us who did this project, and his first draft of the discussion said that self-assessment is useless. And I think that that's wrong. I don't think it's useless. But it doesn't predict patients' and families' assessments. So, can we make a difference? Do interventions to train communication skills help, or is this just either you've got it or you don't? It's innate. And here's a patient seeing a doctor, and the doctor says, "There's no easy way I can tell you this, so I'm sending you to someone who can." And I love this cartoon because I think it really gets at a lot of what I've been trying to do in my career. Is that this is not a workable model, right? We cannot rely on Tony and the palliative care specialists to do all of this communication about bad news and serious illness and so forth. We've got to be able to train all clinicians who see patients with serious illness in how to have some of these basic skills. Can we do that? So one of the earliest and I think still one of my favorite studies of this was done by Leslie Fallowfield in the UK. She enrolled 160 oncologists and randomized them in a factorial design to one of 4 groups. They were randomized to a skills building course where they got to practice, use simulation, get feedback, and try new skills, or to written feedback based on videotapes of them with 6 of their actual patients that were then reviewed by experts, and they were given targeted feedback about how they might be able to improve their skills. And they also randomized a quarter of them to both the course and the written feedback, and a quarter to neither. Outcome assessment now, in this case, was videotaping these oncologists with their actual patients in their practice, 6 to 10 patients, 3 months after whatever group they were randomized, after the training or lack of training in whatever group they were randomized to. And then these videotapes were reviewed by experts and scored based on the expert's opinion about the quality of their communication. And what they found is the skills building course improved a number of things that they were looking for. Use of focused and open questions, expressions of empathy, and appropriate response to patient cues. The written feedback had absolutely no effect. And I think one of the sort of central features or lessons from several of these studies is that teaching communication it's teaching a skill. It's like teaching driving or putting in a central line. You can't do it in a lecture format. You're not going to be able to do it with written feedback or having people read stuff. It's something they have to practice, get feedback on, and then learn how to improve the way that they're approaching it. So that was really the basis for a skills development course that was developed by Tony Bach from the University of Washington, James Tulsky, formerly from Duke, and Bob Arnold at the University of Pittsburgh. And they developed this course that they called OncoTalk, which initially targeted oncology fellows. And this was a study that they did looking at a before-after evaluation of these oncology fellows' skills and communication before this 4-day residential workshop and after. At the time they published this, they had 115 fellows from 62 different institutions across the U.S., and they've now more than tripled that number because this course has continued with funding from the NCI. The way that they measured communication was to have these fellows go through a standardized patient station before the workshop and after. And I differentiate standardized patients from simulated patients in the following way. Standardized patients are trained to do it the same way every time as a way to evaluate. And simulated patients are used in practice sessions and are actually trained to adapt their approach to the information that's coming to them from the trainee that is communicating with them. And they're also trained to give feedback often to the trainee about their experience having received news or having talked to the trainee. So they evaluated, they had standardized patient stations before and after the workshop, different standardized patients before and after, and they found that on average, these trainees acquired a little over 5 new skills in delivering bad news and a little over 4 new skills in talking about a transition to palliative care. As one example, the task in the standardized patient scenario was to give a patient the news that they had diagnosis of cancer. And before the workshop, only 16% of the trainees used the word cancer when giving them that news. Most of them used words like tumor or growth or something else. Afterwards, they increased it significantly, although still only at 54%, so still room for improvement. But that was one example of improvement. Here are the bad news items that they learned that they had. This is the proportion of participants who acquired this skill, didn't have it before, did have it after, and includes things like assessing the patient's perception of what's going on, requesting permission to give the bad news, using the word cancer, I showed you those data, being silent for 10 seconds after giving the news, making an empathic statement after the news, asking for the patient's reaction, and then summarizing and follow-up plans. And these were the skills, obviously, that they taught during these workshops, but they did show that these, in a before-after assessment, these trainees could pick up these skills. We also recently completed a randomized trial now of a slightly different approach where we wanted to try to identify patient-specific preferences about communication, feed that back to clinicians in clinic setting, and then see if that would prompt a discussion about advanced care planning and end-of-life care. So we did a cluster randomized trial of 96 clinicians, and those clinicians took care of 376 patients with COPD who were included in the trial. This was done at the VA hospitals in Seattle. And we got this information from patients beforehand in both groups, but the control group got no feedback. The intervention group got feedback on the patient's self-identified barriers and facilitators, as well as their most important barrier and facilitator, and a suggestion for how the clinician could use that information, and then also about their preferences about end-of-life care. And that was fed back to the patient, family member, if a family member was coming to the clinic with the patient, as well as the clinician. And we found that we had a significant increase in the proportion of discussions about end-of-life care that this feedback form prompted. Went up threefold, but only from 11% in the control group to 30% in the intervention group. So still, most of these feedback forms did not prompt a discussion, but more discussion than without it. And then we also looked at the quality of communication. Baseline on the end-of-life scale that I showed you on a 0 to 100 scale was 21. It went up 6 points, which was statistically significant, and a small to moderate Cohen effect size. So some evidence that we could prompt communication and improve the quality of it, at least as rated by the patient, but effect sizes that I would say were significant but perhaps a little disappointing. Yeah.
Severe with COPD.
Well, that's a good question. This study did not require oxygen dependence. Some of our studies have. I think it was moderate to severe COPD based on FEV1. All right, so that's a little bit of background on making the case that I think interventions can make a difference. Our real challenge is to figure out how, in fact, to do that and hopefully have larger effect sizes than the ones that I think have been shown in the past. So I'm going to talk about 2 recent randomized trials. This is one that was published in JAMA in 2013. And in this study, we used the OncoTalk model. We collaborated with Tony Bach and James Tulsky to use that same model to teach communication with skills building course. It was a 5-year randomized trial funded by NINR. We wanted to do this in an interdisciplinary setting, so we included both internal medicine residents and also fellows, as well as nurse practitioner students, and we required that each workshop include both physicians and nurse practitioners, and that they were co-taught by physicians and nurse practitioners, or physicians and nurses, and we really wanted to make interprofessional communication an intentional part of this trial. It was done at 2 sites, the University of Washington and the Medical University of South Carolina. And we did the study with a little bit differently. We didn't, unlike OncoTalk, we didn't fly the fellows and trainees off to the Rockies for 4 days, but what we did was we had them do 8 half-day sessions during a 1-month time period. So 2 afternoons a week they spent with us in these workshops. They were all started with an interactive seminar discussion and then skills practice. And the communication skills practice progressed. It was they saw the simulated patients were one of 2 patients, one with cancer, one with COPD, and they started by giving bad news. Actually, they started by building rapport. The next session was on giving bad news. There was a session on discussing code status, a session on interprofessional communication, a scenario where they had a ICU nurse come to them and say, "You've got to get a DNR," and they had to talk. They had to use skills to talk with between the trainee and the nurse. Also sessions on talking about death, and then a bereavement session with a family member after the patient in the story died. So they did that over 8 sessions over a 1-month period, and we evaluated this based on some process measures. We, like the study I showed you from OncoTalk, we looked at, in the intervention group, we looked at standardized patients before and after the workshop. We weren't really able to do that for the control group, which is too bad. But it is sort of a before-after analysis of whether skills improved with the workshop. And then our outcome measures, we were interested in looking at outcomes assessed by patients, actual patients cared for by these trainees, family members, and clinicians. And our primary outcome was the quality communication score. We had a series of secondary outcomes, including ratings of quality of end-of-life care on another scale, health status measured with the SF-12, and then depressive symptoms, we're using the PHQ-8. The way that we identified patients was we used the electronic health record in our institution and in MUSC to identify patients seen by these trainees in either inpatient rotations or in the outpatient clinic. And they could be seen by the trainee up to 6 months after the intervention, which I think in retrospect was perhaps part of our downfall in this trial. We enrolled 400 trainees. Most of them were physicians. We actually had a much better participation rate amongst the physicians than amongst the nurses and nurse practitioners. And in retrospect, this was our failing in how we set this up. For the residents, it was either this or a subspecialty clinic. So they were getting out of something to do this. For the nurse practitioner students, we offered credit. So I thought we were going to, get them out of something, but it turns out they all had more than enough credit. So it was really something additional that they had to do. And I think that's why the participation rate was much lower in the nurse practitioners. We sent surveys to over 1,800 patients with a response rate of 58%, a little less than 1,000 family members with a response rate of 73%. And then we also surveyed attending physicians and nurses, floor nurses in the hospital who worked with the trainees and asked them to assess the trainees' communication skills. And we did this before the intervention or control period, as well as after the intervention control period. And we did this all within 1 academic year, but there could be a lag time between the course and the patient receiving a survey that was up to 6 months. The SP evaluations, we had 145 of the trainees who were randomized to the intervention who completed pre and post SP evaluations. These were scored at Duke, actually, by trainers who were trained coders who were blinded to whether this was pre or post. And they assessed 6 skills in the SPIKES protocol for giving bad news, similar to what I showed you before in the in the OncoTalk study. We found significant improvement in 4 out of 6 of those skills. We used a nurse mnemonic for teaching people how to respond to emotion, and the SPs were prompted to display emotion. And of the 5 of these particular responses to emotion, we saw significant improvement in 4 of them. This is the giving bad news, again, the same ones I showed you for OncoTalk. So now we're looking at, I'm showing you pre and post, not just the proportion that gained the skill, but pre-assessing the patient's perceptions, invitation to give bad news, empathy after the news, stating support throughout the care of the patient, and then exploring patient emotions. And those all significantly improved after the training compared to before. So some evidence, although before-after, that we can impart new skills on these trainees. But then with the patient and family outcomes, we didn't see any significant improvement. Our primary outcome for the study was the patient's ratings of the quality of communication on the end-of-life subscale of our communication tool or survey that I told you about. There was no significant improvement. The QEOLC is a survey of quality of end-of-life care skills, no significant improvement. We did see a significant change in depression scores, but it went up in the intervention group. So the group that got randomized to the intervention actually had a significantly higher level of depression after the intervention compared to different patients before the intervention, compared to the group that got randomized to usual education. And there was no difference. We used the same outcome measures for family members, found no difference. And then there was also no difference on the clinician ratings that I told you about. We did a post hoc analysis that was not pre-specified. We thought, well, maybe our inclusion criteria for patients was too broad. Maybe if we narrowed it down to the patients in whom they really should have had a discussion about end-of-life care, as best we can tell, we might see an effect. We looked at outpatients actually first compared to inpatients. We looked at just the outpatients with the idea that maybe this is much harder to do or to evaluate in a busy inpatient setting where there are a lot of doctors, no difference. We did look at the subset of patients who defined their own health status as poor on what I call the SF1, overall how would you rate the quality of your life, poor, fair, good, very good, and excellent. And of the ones who rated their own health status as poor, there was a significant increase in the quality of communication score amongst the trainees randomized to the intervention. But this is post hoc subgroup analysis, so it's hard to make too much out of it. It may be a signal for improvement, or it may be a spurious finding. So we did see that the intervention improved trainees' skills. Also, they improved their self-assessment, parenthetically, which I didn't show you those data. No improvement in patient ratings. I'm not sure exactly why that is. My own bias is that untrained patients may not be very sensitive raters of physician communication skills. I think that patients' expectations are low and they're satisfied with very poor communication. And I think we see that on satisfaction surveys. So it's got me thinking about whether we could actually prompt or train patients what to expect as a more sensitive measure of the quality of communication. I think we're also handicapped by the reality that these trainees are only one of many clinicians that these patients see, particularly in the inpatient setting, but even in the outpatient setting. It may be hard for them to separate out. We did send them, with the survey, a picture of the trainee that said, this is the person we're asking you to rate. If you don't know this person, please return the survey unanswered. But it still may be hard for them to separate that out. We did see a slight increase in depressive symptoms amongst trainees randomized to the intervention, and I don't know what to make of that exactly. It could also be a spurious finding. We had multiple outcome measures, but it's also possible that it's real. It may be that prompting trainees in particular, but any physician, to talk about end-of-life care may actually increase the sense of sadness that patients have as they sort of grapple with their prognosis. And there's some observational data that was published by Jane Weeks in the New England Journal that shows that in patients with cancer, the patients who have a more realistic sense of their prognosis rate their provider's communication skills as worse. And it may be that we just have to accept the fact that if we're using patients' evaluations, that having these kinds of discussions are not going to make people happy. So that's one possibility. The other thing we found actually is that this increase in depression, again, post hoc analyses, but it was more prominent in the R1s than the R2s, 3s, and fellows. And it got me thinking about maybe activating R1s to have these discussions is actually not what we want to do. Maybe they're not at a level yet where we really want to activate them to go out and have these discussions with patients. But that's just hypothesis generation. Okay, so I'm going to finish up by talking about one more trial and then be interested in your comments and questions. But this was a study that we just finished, actually. It's published in the American Journal of Respiratory and Critical Care Medicine, EPUB ahead of print. It's not come out in print yet. Now we're actually looking at, in the ICU setting, critically ill patients with acute respiratory failure and randomized to either our communication intervention or usual care. In this case, the intervention now is a communication facilitator. So we identified a nurse and a social worker that we trained specifically to try to not take over communication, but rather to help facilitate communication between the ICU team and the family. None of these patients could communicate by virtue of their severity of illness as well as endotracheal tube. And so we were really focused on family communication. And they did that through identifying the family's individual communication needs using something called attachment theory, and I'll show you a little bit about how we use that. They were also trained in mediation to identify conflict and try to mediate that conflict, and that could be conflict between the family and the team, but it could also be conflict within the family or conflict within the team. And we enrolled 268 family members of 168 patients. We randomized patients, and so we analyzed this as a cluster RCT with families clustered under patients. The training for the facilitators, they had a 2-day training session with role play based on some of the work that's been done by us and others on how to improve ICU clinician family communication, attachment theory that I'll show you how we use that, and then mediation that I already mentioned. And we had quarterly meetings to review cases and assess fidelity of the intervention. So attachment style is actually, or attachment theory is actually a theory that was developed in the 60s to understand how babies attach to their mothers. So that seems a far stretch from what we're trying to do, but in fact it's been used, particularly with patients with diabetes, in helping improve patient-clinician communication, and has been shown to improve glucose control in settings that use it. And it's divides people into 4 groups based on their attachment style. About half of the population has a secure attachment style. They trust themselves and others, and in that setting, our intervention really didn't make much difference. And then the other half of people divide roughly equally into one of the other 3 groups. The self-reliant attachment style, people who trust themselves but not others. And these individuals tend to be sort of characterized as quiet, independent, and strong. Amongst family members in the ICU with this attachment style, everyone thinks they're doing fine. They're in the corner, the nurses are interacting with them, they're not asking questions, they seem happy, they smile a lot. But in fact, they have a lot of questions that they're afraid to ask because they're afraid that it might somehow interfere with the care that the patient's receiving. And so what our facilitators did was, once they identified that that was somebody's attachment style, then they would encourage questions and concerns and really work with that person to get their questions answered. The third is what's called a support-seeking style, where one trusts others and not oneself. And these are the family members who ask the same questions over and over and over again and don't seem to be satisfied by the response. This one everybody recognizes as, having problems. A little harder to deal with, I think, than the self-reliant group. But what we would do is we would set up a consistent time every day that the facilitator would meet with that family member to try to meet their questions and try to offload the ICU clinicians a little bit and reduce their frustration, and in that way try to improve communication between the family and the ICU team. And then the last attachment style is individuals who don't trust themselves or others. These are the family members who show up maybe on the first or second day, but then are really hard to find and don't come in, and so the ICU team may call a few times, leave a few messages, but not really communicate with them. And our goal here was really to reach out to them in any way we could to try to set up a trusting relationship and try to get them to come in or at least talk to us over the phone. So that was how we used attachment styles. Now, in this study, our outcomes were depression, anxiety, and post-traumatic stress disorder measured at 3 and 6 months after the patient left the ICU. About 30% of patients died in the ICU, about 70% survived the ICU. And then either way, after 3 to 6 months, we surveyed the family members. Our primary outcome was depression at 6 months, and we did see a significant reduction in depression at 6 months. Interestingly, at 3 months, we did not. It was a trend, but it wasn't statistically significant. We saw no difference in anxiety, and maybe a trend at 6 months for PTSD, but no significant difference in PTSD either. So some evidence of reduced depression, although only at 6 months, not at 3 months, and no significant change in anxiety or PTSD. These scores can be hard to read if you don't know these instruments, but this breaks it up into a clinically significant difference in depression score, which has been defined as 5 points on the PHQ-8. And it shows you, if you look at 6 months, it shows you the difference between the two groups, the proportion that had a significant decrease in depression scores, no significant change, and the proportion that had a significant increase in depression scores comparing baseline to 6 months. And then we looked at resource utilization, looking at both ICU length of stay and ICU costs. And here we wanted to look at effect modification by survival status. There's a lot of literature to show that these kinds of interventions can reduce length of stay for patients who die by making decisions earlier, withdrawing life support earlier. It's harder to imagine how this intervention would reduce length of stay for survivors. So we did look at it total as well as by comparing, looking amongst survivors and decedents, stratifying by survival status. We saw no significant change in length of stay for survivors. There was a significant decrease in length of stay for decedents. Similarly, for ICU costs, now if the interaction term actually was not statistically significant, so we looked at it overall, but also by survivors and decedents. Again, no significant reduction in costs for survivors. There was a significant reduction in costs by decedents. And in the ICU, length of stay is the major determinant of costs, but we also looked at ICU costs per day. So dividing by length of stay, do we spend less each day, and did find a significant reduction with the intervention for the intensity of care on a given day in the group that got randomized to the intervention. So the intervention reduced family members' symptoms of depression at 6 months. We didn't see a difference at 3 months. No change in PTSD or anxiety, but there was a significant and fairly large reduction in ICU length of stay, hospital length of stay as well, which data I didn't show you, and then costs amongst the patients that died. So I think this study suggests that there's at least not an increase in depressive symptoms, maybe a reduction in depressive symptoms with this intervention, and it was associated with significant reduction in length of stay and costs for patients who died. We also looked at the proportion of patients who died. There was no difference. Proportion of patients who died in the setting of withdrawal of life support, no difference between the two groups, but it happened, as you would expect, much earlier in the intervention group compared to the control group. So I thought I would sort of lay out what I would do differently now in retrospect with these two studies. I think that although I've spent a lot of my career trying to develop outcome measures, I think we need better outcome measures and more targeted outcome measures. I'm really interested in this idea of focusing patients and families on a discrete communication event as opposed to asking them about somebody's communication skills in general, and then maybe prompting or educating them on what to expect. I've also drifted away from these measures of communication as a primary outcome measure because I think they're problematic and are using the well-validated and responsive tools of psychological symptoms. And then I think we need to figure out how to integrate these interventions into routine practice more than we have. I think I've spent a lot of my career doing research in kind of an ivory tower without directly implementing them into our healthcare system. And I'm really interested in how we can use research in changing clinical practice more immediately and develop point-of-care tools that we can test to help clinicians do their job. So in summary then, I think measuring quality communication is challenging. The interventions, I would argue, can improve communication skills, but it requires in-depth skills practice. And that documenting patient-level outcomes is really challenging in this area. And I think we need more work on how to best do that. And with that, I'll stop, and we have 5 or 6 minutes for any questions or comments.
Does anyone have a question?
That was awesome. Of all the things you said, your point about interns, is that an R1? James was here for so long and did so much with the house staff even before he became clinical. And when I look at things that either our palliative care team or just me personally would be called by a fellow attending and there was a problem with a conversation, it's almost always an intern as opposed to a resident or a fellow. Sometimes it's a fellow out of arrogance, but it's an intern out of just naivete.
Yeah.
Could you speak to that a little more? Because maybe, and one other point, in our culture here at Duke, if you're an intern in surgery or OB-GYN, you're not allowed to discuss things that matter. Whereas in medicine, we encourage our house staff to participate. So given your vast background, could you speak to that?
Yeah, I trained at Hopkins where the R3s would go home and leave the interns at night, and they'd say to the interns, "Call me if you're weak." And that was the culture, And so I think this is really important, and what we're doing now is creating a developmental map for how we teach communication. So we don't teach, I used to teach R1s the same thing I taught R3s and fellows and medical students. And I think that that's the wrong approach. I think we need to figure out, okay, what is the skill set that we need to have at the R1 level, and what can we really expect them to learn and use? And I think we should not be expecting them to give prognoses. You should just say no to giving prognosis if you're an intern without first talking to a resident, a fellow, or an attending physician. I think that they should not be having complex goals of care discussion. I think the reality of our healthcare system is they have to talk about code status, just the way our healthcare system is structured. But what I teach them is you go into the room with your idea of what the code status should be, you talk to the patient, and if those two things align, you can write the order. But if they're not the same, then you back out of the room and call somebody more senior. And I think this sort of idea of let's figure out what we can expect from them. And I actually think we also need to factor in that an R1 is not an R1 is not an R1. I mean, I have had R1s who did fabulous jobs at leading family conferences because they had those skills. Either they picked them up in medical school or they have innate communication skills. So I do think we need to adjust it to the individual, but I think as a system, we need to be thinking, okay, where are they in their training and what can we expect them to be able to do, and then how do we teach that?
Thank you. So just to sort of add to that, and then also I think this comes into the depression higher ratings with the R1s too. So I have the opportunity to teach OncoTalk here as well as the IC fellows and the palliative medicine fellows, sort of the same idea. And what we discover sometimes, and I've talked to Tony Bach about this and Dr. Tulsky, is that occasionally they rate themselves lower on self-assessment afterwards than beforehand because they don't know, and they've never been taught that these are actual teachable skills.
Yeah.
And then they discover that and they realize I'm not as good as I thought I was. And if you ask them later on, they'll call me back or they'll put into practice and they'll say I'm better now. But immediately after, as they're learning their skills, they realize there's a gap there. So I think making it part of the education system is really, really important. And it's starting to take off. It's certainly in the milestones. We're seeing that pop up, but it's not always been there. So
Right.
I think developing these and making it part of, instead of part of the hidden curriculum, part of the actual curriculum is really going to help them to get better at these skills that'll make a difference in our
Yeah,
patients.
I think it's a really good point, and I'm looking for the data set to show this, but my hypothesis is that there's a U-shaped curve, that the novices don't know what they don't know and they rate themselves good. As they start to learn, and this is sort of what you're saying, they start to learn and they realize, ooh, there's a lot of stuff here I don't know. And then as they move towards expert, their self-assessments will realistically go back up.
Oh, okay. I love this discussion, and I work in the cardiac intensive care unit, so I deal with a lot of people. We get all the overflow from the medical intensive care unit because those guys can't take the hard patients.
Because they're weak, right?
They're weak. And I was originally going to ask another question, but then Tony's question prompted me to think about this whole business about the mandated discussion about the code status, which drives me crazy because, I think I'll be able to tie this in with my original question, that having a 30-second, 1-minute discussion about what you want at the end of your life, if things don't work out well, you just got admitted to the intensive care unit, we don't know what's wrong with you, but what do you want, seems like a kind of silly thing to do. And periodically, I stand at the door and I look in the room and I see a person that looks pretty normal, and the fellow or the resident usually presenting says they're DNR.
Yep,
I
I
said,
had
what?
the same experience.
What do you mean they're DNR? Why? Well, they just wanted to be. Did you ask them, what? So they don't question that stuff.
Right.
And I just, but it gets to the point of when you go in on rounds, can you actually have a discussion about this that's meaningful within the allotted time that's available to do that job?
Yeah.
And I don't think so. So we end up having these pro forma discussions, and our biases kick in. If the patient looks old and kind of decrepit, and somebody says DNR, okay, we're not going to kick that tire too much. But if they look young and healthy and they want to be DNR, well, forget about it. Then something's wrong. And I don't know that that's the actual intention of that whole discussion in the first place. But it gets to the deeper question about how the reason a lot of patients don't want to have these kind of discussions is because they think that somebody's got the key to fixing them. Death is optional, and we just got to find the right guy to figure out how to get me out of this jam. And, so you got somebody coming in who's saying, well, we can't do anything more for you. Fine. Go find somebody who can do something, all right? Don't tell me you want to put me on palliative care and get Galanos to come and see me. I want somebody who's got a more positive attitude. And
He's a pretty positive guy.
So how do you, I think that the point that I'm trying to get to is I think that the persuading people that we've actually done enough to really have that conversation is a more complicated thing. And maybe we need to think about, communication style is obviously a key part of it and establishing trust, but maybe we also need tools that's sort of quantitative tools even, and a more, we're in the information age now. Maybe we need to have a different kind of presentation to people to say, yes, we've kicked these 20 tires and look, this is what it is. And, if you want to drill into this and make sure that we haven't overlooked something, we're happy to do this journey with you. But at the end of the day, this is what it is.
Yeah. So I think those are really good points, and I'm going to mostly agree with everything you said. I will say, though, that I think that there are different kinds of conversations. about code status. And I think that the conversations that we should and can have in 30 seconds when people are admitted to the hospital is, has anyone talked to you about this before? Have you thought about this before? Do you have a set preference for what you want that we ought to know about? I think that's a conversation that an intern can have and that you can have in 30 seconds or on rounds. But I completely agree with you that to try to distill the goals of care into a 2-minute or 30-second conversation is wrong-headed, and it does lead us down the wrong path. And I've had the same experience of a 45-year-old woman with no chronic illness, and they say, oh, she's DNR, and then we go into the room as a team, and in fact, what she meant is that if she has a terminal illness, if she develops one, which she doesn't have, she doesn't want to die on a ventilator, which is very different. So I think that's a learning opportunity. Is, look, you just told me DNR, let's go in and have this discussion quickly with her. And I think you can do that. You may want to come back and do more, but you can sort of show, oh, in fact, you jumped to that because you're trying to check a box, and that's not the way you want to approach this. I also think one of the things that drives me nuts is we'll get a patient with a chronic life-limiting illness admitted to the hospital, and by the time I see them, 12 people have asked them about their code status. It happened 4 times in the ED, and the nurses are doing it, and everybody's doing it, and it's like, enough already. The patients are pissed by the time I get to them because they're like, everyone's trying to make me DNR, stop already. So I do think we also need to teach people about that phenomenon and sort of say, look, you can ask about this, but you got to understand that it's in the context of a bigger discussion. But there may be something that we really do have to get out of the way in the middle of the night, because if something does happen, we want to know about it. And we don't want to put somebody through something that they have thought about before and really wouldn't want. And I love the idea of using technology, and Chris is actually leading the way. Chris Cox is really leading the way in thinking about how do we use technology in iPads and use the EHR to help facilitate this in a nuanced way to allow teams to have the information they need, allow patients and families to have the information they need to then have better conversations. And I think that's the future. I'll tell your study section that too, Chris.
Well, it's been fantastic. I want to thank everybody for coming, and especially thank Dr. Curtis for a great discussion and presentation. Thank you.
Thanks.